Hello and welcome to today's webinar, Disruption or Distraction, Solving Staff Burnout. Currently everyone is automatically muted, but if you have any questions, you can type them into the question box and we can answer them during the Q&A at the end. My name is Tom DeSantis from Laudio, and one of my jobs is to organize our Thought Leadership webinar series, so I personally want to thank each of you for logging in today. For our agenda, after the introductions, I'll welcome today's guests. He'll talk about how we guide organizations through innovation. We'll introduce our specific technology focused on solving staff burnout, and we'll conclude with your questions. I've planned this to be for about 30 minutes. So before we begin, I wanted to tell you about Laudio. We're a healthcare technology company based in Boston, and right now I'm trying my hardest to suppress my accent, I promise. I'm supported by research on staff retention and turnover, specifically nurse turnover. We were founded by a group of clinicians, technologists, and analysts to solve the employee burnout issue across healthcare. In this graphic, you can see that physician burnout has been long researched and talked about. Yeah, we believe it's the tip of the iceberg. Staff burnout and its dramatic impact on the bottom line is the problem we're solving. I want to introduce my colleague, Tom Hills, who will talk about that later in the discussion. Welcome, Tom.
Thanks, Tom.
At this time, I wanted to welcome Dr. Ronald Riner. He is the president of the Riner Group and a leading voice in healthcare transformation, and he's a Laudio advisor. As you can see from his credentials, he provides a perspective not only as a physician, but as a healthcare executive who has worked at and worked with some of the top health systems in the country, helping forward their missions. Welcome, Dr. Riner.
Thank you, Tom, and thanks to everyone for allowing me to join you this afternoon.
Sure, but so before we dive in, tell us about the Riner Group and your role working with U.S. hospital leadership.
Well, thank you. Yes, we've been an advisory firm for almost 30 years, or a little over 30 years, and our work revolves around strategy, business development, and performance improvement. We work with hospitals, health systems, large medical groups, and other healthcare delivery motifs across the whole United States. And so in the course of that 25 or 30 years, probably haven't been missing too many of the major systems in there. So it's a pleasure to be able to be with you today to share perspectives.
We're completely pleased and happy to have you here today, too. So as we explore nurse burnout today a little bit, we've asked you, Dr. Riner, to provide your thoughts on innovation in healthcare. And we know there's been a steady stream of articles about disruption in healthcare, especially I saw a bunch actually this week that came out in, I think, some of the HIMSS publications, about how disruption for the sake of change isn't always the best decision. In fact, a portion of the $11.5 billion raised in 2017 for digital health startups is arguably a distraction for some clinicians, really just trying to deliver quality patient care. And that's not always about the EHR and all of the challenges that come with integrations there. It's both clinical and non-clinical, and as you know, we're a non-clinical solution. But Dr. Riner, you have 5 recommendations for hospital leaders to follow if they want to be strategic about innovation. First, you tell us here on the first slide, be pragmatic. Tell us what you mean by that.
Well, Tom, you know, there's just no shortage of recommendations that one could make in terms of the changes that are occurring in healthcare delivery. And I think, as you just referenced, frankly, change for change's sake is not really what I would recommend. I think the people who are on this call are predominantly from the C-suite or from managers in the trenches, and I would just say being pragmatic, looking at what makes sense, be selective. There's no question we have burnout, and in part that's a consequence of not looking at what makes a difference, what's going to make people feel like they're doing purposeful work, or that they're doing unnecessary superficial things that really don't matter. So that's very, very important. Second, I think in terms of interacting with your colleagues in various settings, my observation is that sometimes we get down in the tooth, or we have a tendency to blame someone else for why we're doing it. My experience has been that if we can set things that we have to do in the proper context and talk about the why of we are doing it in a future forward sense, it energizes people more than saying that, oh, we're just doing it because we've been told by CMS to do it, or we're told that we've got to do this, or we won't be able to get paid for why we're doing it. Healthcare is a very, very different industry. I'm biased, obviously. As a practicing physician for many years and as someone who's very focused on healthcare delivery, I think there are differences between healthcare as an industry and other industries. And so I think a forward-looking approach, concentrating on what makes a difference, and putting it in the context of, this is something that is going to be very purposeful for us in the long run or support our purposeful activities, and we'll come back to that in a few minutes.
Excellent. I was thinking as you were speaking, one of the things we hear a lot when we deal with health systems and talk to health system leaders is they want to know about enterprise solutions. And I mean, in our space, those are some buzzwords. And I know even the clinicians on the line probably hear that. We're fortunate at Laudio that we are an enterprise solution, but I've worked for other organizations where, for example, we benefit just, let's say, the orthopedics department, or it could be a department. What's your sense, and some folks will say to us, we won't evaluate or look at you unless it's, enterprise-wide. Like, what's your thoughts on that?
Well, candidly, I think it depends. There are circumstances and situations where only an enterprise solution may fit the bill. There are other solutions, I think, that are worthy of piloting. And in my experience, again, people are sometimes more inclined to take a particular solution rather than an enterprise-wide solution to prove that it works and to build support for the funding of it and for the development of it. So, again, it's different in each organization. Each organization has its own culture and its own way of approaching acquisition of technology. I think you have to take it one at a time when you look at that. And at the end of the day, if those of you who are supporting it feel that it's beneficial, then I think it's incumbent upon you to say, okay, how are we going to get it done? If taking a piloted or a more focused approach is more likely to be accepted, go that avenue and prove its worth. Or if your organization doesn't do that and only accepts enterprise approaches, build a case for that if you think that this is going to be advantageous for you or the technology under consideration would be advantageous.
Agreed. Okay, let's move on to your second recommendation. Embrace and court outsiders. Obviously, we have a bias on this one, but explain your position on this.
Yes, we have a tendency in healthcare, as other industries do, but especially in healthcare, to become somewhat insular. And with some justification that the lexicon of healthcare and the activities of healthcare sometimes call for certain knowledge that is not easily understood or interpreted by people who have not been accustomed to working in that environment. On the other side, however, I think because we sometimes are so insular, it's important to embrace and to acknowledge the expertise that exists in other industries and to court that to a certain extent so that you can learn from what they have accomplished and say, okay, how do we make that applicable in our particular environment, given our skill base, our understanding of the industry that we have. Long story short, I think that you must be open-minded to other individuals who come from other areas. On the other hand, I would say those individuals also need to be open-minded and understand that they are entering into an industry that doesn't work just in zeros and ones. Our focus is on people and the things that go along with human nature and people when they're at their most critical points in their life history. And so it's a dance that I think, if done correctly, can be very advantageous. And for the people on the phone, I would say that if you close your minds to people coming from the outside, I think you're going to miss opportunities that could be very advantageous to your purpose as a healthcare giver.
Yeah, thank you. Recommendation number 3 here: fight complacency.
Yeah, this is an interesting way. You were going to say something, Tom.
No, I was going to say, what's your point of view? I mean, I know my own as a technologist, but yeah, tell us.
Well, complacency hits all of us to a certain extent, and ironically, it's probably more prevalent in organizations that have been successful. If it's working, don't fiddle with it is an adage that many of us have grown up with of sorts. And I think that in the long run, this can come back to be disadvantageous as well. I think every organization today, given the rapidity with which technology changes, with which the rules and regulations change, we've got to be nimble and flexible as an organization. And I think you have to say that change is difficult for everybody. But again, if you throw up a barrier to every aspect of looking at things differently, you will be disadvantaged in a competitive sense, and you'll be disadvantaged in terms of your ability to look at new technologies, new ways of treating the patients that come to you for their care. So it's a natural tendency to fight change. My experience would be that if you keep an open mind, the complacency issue evolves as you get more comfortable dealing with aspects of change management in that respect.
Yeah, as you were speaking, when you said the word nimble, so we talk to large organizations with multi-million-dollar budgets and such, and budgets are set and they're fairly rigid in terms of timelines. How can you be nimble or flexible when you're dealing in that environment? What is healthcare doing, as a result of that kind of rigidity that they're trying to break down?
Well, I think there the succinct answer is how is it possible? The answer is with great difficulty in some instances. Yeah. Especially in our environment where we've gone through so many mergers and acquisitions, and those organizations are somewhat neophytic at this point. They're in their early infancy in terms of coming together, and so the complexities of newly formed organizations make it quite difficult at times to track through that. But at the end of the day, if there's probably one industry that needs to look to innovation to assist them in dealing with the complexity, I think it's healthcare. Some organizations in healthcare do it better than others. Those, in my experience, again, are organizations that allocate funds, establish sort of innovation centers, go out and specifically identify people who have innovative approaches to thinking about changes and activities that they are willing to take a risk on. And as probably everybody in the audience knows, healthcare in general is a very conservative, appropriately so, conservative approach to how we apply things. We do things by scientific evidence. We do things by, controlled trials. So you're fighting all the time to say, okay, how do we become a first mover? How do we become an early mover in looking at these areas? And you really have to sort of grow that expertise within the context of your organization, and you have to protect it so that it can flourish, and you have to have the right people in the context of that innovation center to make it happen.
Yeah, as you were answering, that's the first thing I thought of, sort of the rise of these chief innovation officers and how more and more hospitals are adding them to their arsenal. So I think that's going to really kind of move the dial. That's at least what we're hoping for. So yeah, I agree with you in there. Here we go. Another recommendation, have a meaningful purpose. And I think you already touched upon that, but maybe you can expand.
Well, I will tell you that this is the glue. This is the glue, and it's also the rough edge for why I think so many people are burned out, whether they're nurses, physicians. We are so inundated again with requests for regulation compliance, data entry, metrics, dashboards. And from a caregiver's vantage point, that's probably a distraction. At the end of a heavy day where you've been spending 40–50% of your time doing administrative things or not being able to be at the bedside, where most clinical caregivers feel the action is, they feel that it's non-purposeful. It's wasted time, energy, and effort. And candidly, if you look at some of the data, some of the things and many of the things that we're asked to do in healthcare today have yet to be proven to make a difference in the long run. Don't misunderstand. It's not that I'm denouncing measurement or metrics or dashboards, but again, I think purposeful activity, focusing on the values of the organization and disqualifying initiatives that out of the box seem meaningless or can't be supported as making a difference in the outcomes of what we do. Even the electronic health record that everyone is touting, we see everywhere, is at this moment in time, and I could be challenged for this, but I would say at this moment in time is predominantly an administrative tool. It doesn't walk, talk, and think like clinicians or nurses in the trenches, in large part because it was developed by some of the things we've talked about, people who don't necessarily walk and talk and deliver health care like those in the trenches. So I think the purpose is such an important aspect of looking at this. When you look at technologies to support it, I'd have to say How do you enhance my ability to do what I think is meaningful? How do I engage with the people in a manner that enhances their ability to be feeling as they're part of a human team that is doing these things that make a difference? And at the very end, you don't want to, when you look at various aspects of acquisition of technologies, merely add to the bureaucratic overhead and the bureaucratic encumberments that come with what people think are non-meaningful work. So to me, it's the glue. Purpose, value is the glue that makes people get up on a hard day or do a long day and come back for it again the next day.
Hey, Dr. Riner, it's Tom Hills. I had a follow-up question for you on this area. I was just at a prospective client site 2 weeks ago meeting with their very senior leadership there, and they had indicated frustration about how they communicate their meaningful purpose into the organization. They had just gotten back a nurse engagement survey, and despite a lot of effort they thought on their part to be able to communicate this meaningful purpose clearly, the engagement survey came back and told them, unfortunately, the opposite of what they had expected. Do you have any words of advice in terms of how this purpose can be, can actually be driven into the organization?
Yeah, it's a good question, Tom. Your organization that you talked about there is not alone. I would say that the concept of engaging the people in the trenches, the people who are delivering the care, is a challenge for almost all organizations, and even those organizations that have it down or think they've got it down are challenged daily on how to maintain a relationship with the people, reward them, engage with them, talk with them. Healthcare at its basic is a human relationship undertaking. And so systems, and hopefully some of the technologies that you'll share with the folks here, are ways of saying, how do I maintain the humanistic aspects of personal interaction rather than to make it something that is remote and that I can't put my hands on a regular basis, or that I see Sally or John or Joe once a month instead of more frequently as I would ordinarily if I was working shoulder to shoulder with them. So I don't have a succinct one-size-fits-all, but I do know that it's activities that increase interaction, dialogue, and contact with people in the context of healthcare delivery.
So that actually might even, drive us into recommendation 5, engage younger colleagues and talent. And at first I found this one to be surprising, and then I thought about it more, and, we're talking about a generation that's grown up with devices, and those of us in different generations that have had to adapt and learn really quickly how to use technology. So it kind of makes sense. Talk to us about this recommendation.
Well, there's a lot said about, how do we engage our younger colleagues, and, as someone who teaches business of medicine courses and make rounds in hospitals, I will tell you that there are differences. There are generational differences. But again, those generational differences are a reflection of a lot of different factors. And a discounting or a rejection of younger folks that will be joining our profession simply because they are youth or they're viewed as people who approach life strictly digitally, I think is a discounting of what can happen if you do it correctly for the benefit of patients. There is no question that our environment in healthcare is very fractionated. We have hospitalists that change every 8 hours. Patients complain that they don't see their own doctor, that they don't come to the hospital to see them, and so forth. And into that mix is a dialogue that everything will be cured by artificial intelligence, and one day we'll have Arthur the robot talking to us. But at the end of the day, I doubt that you can replace the human interaction, the sense of tragedy, need, want, death, mourning. And our younger colleagues, as they engage in the environments in which we're working, I think can bring an appreciation of the technologies that will be helpful to us, and at the same time, those of us who are more mature in the process can teach them about some of the things that will need to be part of that digitized environment. And it goes back to what I just said. I think it's engagement, contact, and interaction with each other more frequently, not less frequently. And that has to be resonant, if you will. All of that has to be resonant with the values of the organization, with the culture of the organization. And I would just say in healthcare, you know, where we talk about from an operational standpoint accountabilities. Accountabilities build structure, structure builds culture, and the culture is a reflection of the values that the organization hires, fires, and lives by. And I think our younger colleagues have a lot to bring to that equation. So, you know, I would not, frankly, favor discounting use of younger colleagues in any way.
Yeah, I think that's an important point. You know, you talked about AI. I think it was the AMA that said, you know, it's not really artificial intelligence, it's, you know, augmented intelligence, and it's all about supporting the human and people. And here at LawDo, we're all about people, technology to support it. But that's what we do. So we're healthcare's first staff relationship management platform. And to health systems that use LawDo now, I think we check all the boxes, Dr. Riner, that kind of you recommended to us, and they'll say that. Tom Hills, at this point, I want you to jump in, start walking us through the innovation we have, and talk about how we're helping hospitals accomplish this.
Yeah, sure, Tom, and we'll be quick here. The thing that's interesting about LawDo is we would say that we're changing the paradigm of staff leadership, especially for large teams, which today is unstructured, it's fragmented, and it's largely manual. Instead, LawDo is it's one of these purposeful innovations, a platform that creates and sustains structured, repeatable, and trackable leadership best practice. We reduce burnout, we save managers time, we support collaboration of team leads, we drive best practices, and we standardize behavior. The proven results that we've had, that we've experienced so far include increased engagement and lower burnout and turnover, and importantly, we've been able to connect this to financial return to an 11-to-1 ROI at one of our pilot sites. So how do we do this? About 18 months ago, maybe you can just go back one slide there, Tom. Sure. Our team was really drawn to the problem of staff burnout. We all have had past experience growing healthcare technology companies. Research and our own experience told us that burnout, especially among nurses, is widespread, it's non-discriminating, it affects health systems of all sizes and care settings, and it's costly. Since staffing comprises some 60% of operating costs for most hospitals, this is really a critical issue. So that caused us to really dig deeply and begin conducting what's become hundreds of interviews with healthcare leaders and managers. So on the next slide, what you'll see is that we've learned, perhaps not surprisingly to those of you on the call who are working in this day-to-day, but that the manager, the direct manager, is at the center of burnout-related issues. And in fact, the single greatest reason we found why staff leave the organization is a poor relationship with their immediate supervisor. I really like, Dr. Riner, what you had said about healthcare really being associated with human relationships. And you'll see here 3 actual quotes from burned out nurses we interviewed who are self-admitted flight risks in their hospitals. And note that we've mapped them to categories of work that should be priorities for their direct manager. And you can see by their responses they're not. So what's going on here, you know, why is the average annual turnover rate among healthcare systems 20%, which seems ridiculous? And certainly it's one of the highest of all industries. The answer can be found, we believe, with the direct manager. Because despite their critical role, direct managers themselves are overburdened. They tell us by huge spans of control. They report having field trained and are frustrated by working across a myriad of paper-based software systems in order to be effective. So that's really what inspired us to create LawDo. There are 3 capabilities that make this platform unique. First, and we'll take each of these in turn in a second, LawDo centralizes systems and leadership into one platform. We analyze predictive data so managers can act with greatest impact, and we standardize a management playbook under one framework. So we'll cover each of these now in the next 3 slides. First, we give managers a single platform to more effectively manage and collaborate with their teams, with the purpose of saving managers time. We combine and streamline workflows. We bring together data from multiple disparate systems, like time and attendance, HRIS, and even paper-based systems like sticky notes and paper files. And then we automate work such as attendance and outreach and documentation. We make it easy, for instance, to find someone on the floor if they're working today, or send them a text or email, or make notes that become part of their personal file and can be viewed at a later date. Laudio also connects the leadership team. We allow the manager to delegate tasks and share conversations and next steps with team leads. So that's the first part about saving managers time. Next, we give managers insights. We analyze the data we ingest. We suggest actions that Laudio predicts will have the greatest impact on team members at any particular moment in time. We're doing that through a very sophisticated analytical engine that underpins the platform. This enables managers to interact with their staff in the most timely and effective and efficient manner, and all activities tracked and measured and updated in real time with views either at the team level or at the individual level as well. So this allows me, if I'm the manager, to see if I'm addressing issues in a fair and consistent way, or if I've neglected to recognize certain individuals. And third, we provide a measurable framework we call CARES, which you can see in the upper left-hand corner of the slide here, to drive consistency, best practice, and benchmarking across the hospital or the health system. This CARES framework has 5 elements: celebration and recognition, accountability, risk of burnout, employee development, and finally staff and unit issues. It's been developed from peer-reviewed research, including that conducted by Cheryl Jones, who's director of the Health Scholars Program in Nursing Innovation at the University of North Carolina, and is also affiliated with Penn Medicine. Now, Cheryl has published hundreds of studies on the organization and delivery of care. What we've done is we've been able to operationalize CARES so that it can become the manager's playbook, which reduces variability in the practice of managing staff across the health system, especially staffs of very large size. This playbook helps managers manage to each CARES element to increase the frequency of recognition, for instance, or help ensure adherence to work standards, or act quickly when someone's exhibiting signs of burnout, or provide the right coaching and development to each team member at the appropriate time, or consistently remembering to follow up when team members identify an issue on the floor and I, as the manager, have promised to do something about it. So it's important to emphasize Laudio is not a reporting tool. We call it an action platform. It helps me, for instance, in this case, know when Sophie needs to be recognized for floating, or on this next slide, have a conversation with Ashley about why she's working less than expected. On the next slide enables me to talk with Robert about why he's working so much and is his fatigue threatening patient safety. It helps me remember on the next slide to check in with new team members to provide them the support they need. And embedded on the next slide throughout the platform are helpful tools and templates to save me time as I interact more frequently, following up on my promises and documenting my interactions. And this includes the tracking of activity that gives me insights on the next slide, both across my team and at the individual level. So Laudio is making a difference. On this next slide, you'll see past 4-month data from a beta site at a large tertiary care hospital that's part of a larger academic health system on the East Coast. And you can see the turnover among the 3 Laudio units measured here was 2.5% lower than that of the rest of the hospital. So the hospital is now expanding Laudio and expects an 11-to-1 ROI from its investment. But more importantly, the upside is not just financial. By increasing the number of timely and meaningful conversations, these things that Dr. Riner talked about earlier on, managers are able to help their teams work to their fullest potential, increasing their satisfaction, which then in turn creates higher levels of safety, quality, and the patients feel it too in terms of higher patient satisfaction. So net in summary, what we're doing with Laudio is we're giving managers and their leadership teams a single place to manage their staff. We are giving them tools and insights and tracking to save time so that they can execute consistently throughout your organization. And we're bringing clients a measurable management system that's based on research and best practice.
Thank you, Tom. I appreciate you getting us through that to try and keep us on time. At this time, I have 4 questions, just to let you know, that have come through. And that's the end of our formal presentation, but two of the questions are for Dr. Riner. One of them, people want to know if this is going to be the recordings available or the slides. The recording will be available. It'll be on our blog, on our website, LawDo.com. We'll also be sending it to you directly. And so if you stay on the line, we have, like I said, 3 more questions. Dr. Riner, this one's for you, if we could bring you back in.
Sure.
It's sort of specific to one of your points. But do you believe it's better to purchase by committee, or do you feel that that slows down the decision-making?
I think it depends on the vantage point. Putting more people into the equation can slow the decision-making process. There's an old adage that it's good to be king or good to be queen. On the other hand, if you're looking at it from the vendor's vantage point, getting more people to see it, know it, touch it is advantageous from that point. In today's environment, with the emphasis on team care at the bedside and with these types of technologies impacting team care at the bedside, especially what I've just seen here, I would say that it's likely that more than one person is going to make the decision. So a committee approach, and early on, getting people involved and understanding what it does is one of the major hurdles to get over, so that people begin to get a comfort and get then into the weeds of looking at what it costs and how it's implemented and so forth. But you've got to look at people changing behaviors if you go to something that's going to change delivery at the bedside.
Excellent, thank you. Someone wanted us to elaborate on our research. How did that inform the software, or what I would call the platform? So I do know you talked about the sort of the peer-reviewed literature and Cheryl Jones and her work. So we've built a foundation upon that. We also looked at research with interviews with nurse managers and nurses to kind of figure out that the nurse manager really is a critical, pivot point in this whole process. And then also we did a larger study, and maybe you can help me with it, where we looked at people that have left their organizations, kind of back mapped to see what their reasons were, and looking at their, for example, time and attendance or other indicators.
Yeah, sure, Tom. What we've done is we've now ingested data, primarily time attendance and HR-related data from some 20 different hospitals and health systems across the country. And we've done a lot of sophisticated analysis, historical analysis. We've looked at data over a 3-year period. And what we've been able to do in taking that kind of a cross-sectional view is we've been able to identify between, well, now it started out to be 60 observational types. Now it's grown to about 100 that are highly correlated with burnout and attrition. And so what that allows us to do, once we've identified these particular, what we would call key performance indicators, with each new client that we bring onto the platform, we can, one, conduct an analysis of their data, of their historical data, look and see how that maps in with the data that we've already collected and mapped across this variety of other health systems, and then identify particular observation types that we can measure and monitor, if you will, over time. So some of those observation types that you saw previously on the last few slides are drawn from that analysis.
This is the third and final question. Dr. Riner, I'm pretty sure this one's for you. What do you feel is an emerging strategic initiative across health systems? And you have permission, it doesn't have to be about workforce development or LawDo. What are you finding out in the field?
Well, we could talk about this one all afternoon. There are a lot of emerging ones, but I would say a couple of things. Given the complexity of the environment in which we see, there's more and more fractionation of care and handoffs being problematic, and people being dissatisfied with issues of continuity and interaction. I think that again, there's the ever-emerging and continuing reach for technologies, and as I say, I could go on to many, many others that as a strategist working with C-suites and boards, I could talk ad infinitum about. But I would say that if there is a trend, there in the conversations at least, and in some areas, and just what I've seen here, I think it is going away from disruption and discontinuity, especially change for the sake of change. Maybe the word should be we're looking for things that are enhancers and enablers to what clinicians have long taken pride and satisfaction in which patients come to expect when they come to their caregiver. So I would look, I'd end on the words, maybe think about enhancing and enabling, and not so much, as you put on the title, disruption and dissatisfaction. But those trends that can play on that, I think will be helpful. And the distractions are going to be numerous, but again, those that enable, those that enhance, I think will rise to the fore.
All right, Dr. Riner, thank you for that answer, and also thank you for giving us your time today and for helping us with Laudio. We appreciate all that you contribute. And to everybody that stayed on the call, we thank you for joining today again. And Tom Hills, thank you for helping me out. And so from all of us at Laudio, enjoy the rest of your day. Thank you.
Thank you. Thanks, everybody.